Tuberculosis arthritis is a subacute arthritis secondary to Mycobacterium tuberculosis infection. Tuberculosis arthritis is a common form of septic arthritis. Tuberculosis is endemic in Asia, the Middle East, and Africa. Skeletal involvement is seen in 1 to 3% of patients with tuberculosis. Half of those affect the spine, while the other half affect extraspinal osteoarticular joints. However, not all those with tuberculosis arthritis have pulmonary manifestations, as this is only seen in 50%. Most common musculoskeletal sites are weight-bearing joints, spine in 40% of cases, hips in 13% of cases, and the knee in 10% of cases. TB may reach the joint cavity either through spread of infection from the subchondral region, via blood, or by direct inoculation. An immune reaction known as granuloma would then ensue. If the infection reaches the synovium, it will become a pannus that would encroach on the surrounding structures, resulting to bone destruction and joint space obliteration. Cartilage destruction occurs at a later stage than in septic arthritis, since there are no proteases in the synovial cavity. The infection may spread to adjacent structures. Eventually, the joint will fibrose and stiffen as fibrotic ankylosis. Rice bodies containing fibrin and dead synovium may also occur in the long run. Now for clinical manifestations. TB arthritis is a monoarticular and of insidious onset that commonly presents with chronic joint pain and only minimum sign of inflammation. It involves primarily weight-bearing joints, the hips, knees, and ankles. Common symptoms include local pain and swelling, restriction of movement, muscle wasting and deformity, systemic symptoms such as fever, weight loss, and night sweats. Only half of active TB arthritis cases present with these systemic symptoms, however. Now we go to our diagnostic findings. Synovial biopsy is the gold standard diagnostic measure for TB arthritis. A positive result would include findings such as caseating granulomas, lymphocytes, giant cells with caseation. 2 to 5 months after its onset, pertinent findings in radiologic imaging would present with a triad of characteristics, namely peripheral osseous erosions at the point of synovial attachment, juxta-articular osteoporosis, and gradual intra-articular space narrowing. Mainstay anti-TB treatment is the only curative option for TB arthritis. Drug choices for this treatment includes a combination of 4 different drugs: isoniazid, rifampicin, pyrazinamide, ethambutol, or streptomycin. 12 to 18 months of chemotherapy is recommended for its full effect. However, for the increasing common variant of multi-drug resistant TB, administration of 4 new drugs, moxifloxacin, linezolid, para-aminosilicic acid or efionamide, and clofazimide should be administered for not less than 18 to 24 months. For symptomatic relief, splinting and joint immobilization is recommended to reduce pain. Additionally, synovial fluid drainage is recommended in order to remove destructive enzymes and inflammatory agents and decrease the pressure, therefore decreasing pain. Arthrocentesis, arthroscopy, and open surgery are procedures that can drain the synovial fluid. In worst cases, wherein there is severe cartilage destruction and joint deformity, surgery can be performed. Synovectomy, arthrodesis, arthroplasty, debridement, and amputation are options for these patients. For prognosis of TB arthritis, articles have stated that if there is minimal bone involvement, articular disease could be successfully managed with drug therapy alone. It could result to neurologic damage, and in older series, mortality was as high as 20%. Other recent studies stated an almost 80% resolution of even severe cases with appropriate drug therapy. Predictors for poor prognostic outcomes commonly include age of over 60 years old, delay in diagnosis, existing comorbidities such as diabetes mellitus, underlying joint diseases like rheumatoid arthritis, osteoarthritis, and immunosuppression. With regards to causative agents, poor prognostic outcomes were attributed to presence of Staphylococcus aureus and Neisseria gonorrhea, with a mortality rate of 50% from the former and extremely low mortality rate of the latter despite optimal therapy.